I simply want to say that Michele Tepedino is an out of rules medical doctor, because you will check yourself that he understands rather well mechanics and is producing for us interesting problems. So, in a sense, I'm asking you to be not too aggressive, because we may meet him one day, he's a medical doctor, and on the other side, he gives us very interesting ideas. Okay? So please.
Okay. Thank you, and thanks to the organizing committee for this kind invitation. It is really a pleasure for me being here. And as Professor Dell'Isola said, I'm an orthodontist, so my lecture will be quite different from the one that you listened to previously. And as many of you probably already know, orthodontics means the branch of dentistry that is dedicated to the correction of dental and skeletal malocclusion. So practically what we do, we start from this mess and we try to change the position of the teeth until we reach a beautiful functional occlusion. And we do that through different kinds of appliances. These are just some examples of the armamentarium that we can use. But all of these appliances have in common the principle that if we apply a prolonged pressure to a tooth, we will see that tooth moving in the direction of the force. And this happens through bone remodeling. If we see this example, this is a device that is used to move the posterior teeth backwards. And after a couple of months, we see a space opening here, and this space is filled with alveolar bone. So there is no doubt that this process is happening through bone remodeling. The problem is why we are seeing this phenomenon. So what is behind? The topic of the Congress is complex system. This is quite a complex problem, okay? We define orthodontic tooth movement as a load adaptive response of the structure surrounding the tooth to a force system that is applied to the crown. Many theories have been proposed to explain this phenomenon. The bone bending theory states that the bone is deformed via the application of the force, and so stress lines are created inside the bone, and those stress lines are the trigger for bone remodeling. But the most commonly accepted theory, and also the one that is commonly taught in every orthodontic school, is the pressure tension theory. If we apply a force in this direction, we will have that the bone here will be compressed, and so we will have bone resorption here, and we will have tension on the opposite side and bone apposition on the other side. It seems pretty straightforward, but it is not. Indeed, if we accept that we have bone resorption on the side of force application, we must accept also that alveolar bone behaves in a totally different way than every other bone in the body. Because we know from the mechanostat theory by Frost that we have bone resorption when the bone is unloaded and new bone formation when the bone is loaded. So we would expect bone formation here, but this is not happening. Moreover, typical orthodontic forces are not able to reach the threshold of strain that is necessary to initiate adaptive bone remodeling. And in addition, orthodontic forces are more or less constant and static forces, while we know that only dynamic strains are able to trigger bone remodeling. So we have some problems. And the reason why we observe this discrepancy between what we would expect and what we see is the presence of a soft interface between the tooth and the alveolar bone. we know that the presence of this interface that we call the periodontal ligament is important also because when the ligament is absent or when its function is impaired because of a pathological condition, orthodontic tooth movement is not happening. So let's take a little step back and have a closer look at this structure. The connection between the tooth and the bone is a very particular kind of joint. It's a unique joint in the body. We call it gomphosis. It's unique because we have a large number of blood vessels and a rich innervation within its joint. This is something that is not happening elsewhere. And practically, the tooth is connected and suspended like a hammock-like structure made of collagen fibers to the alveolar socket. And the thickness of the ligament is not even. It is wider at the top and at the bottom and thinner in the middle. And these double goblet shapes allow the tooth to tilt and move easily inside the socket. And this is the latest evolution, the latest innovation in evolution, because only crocodiles and mammals have this kind of interface. And this is probably one of the reasons of the success of this species, because having this kind of attachment means that you have superior hunting armamentarium. Because having a soft interface of this kind between the tooth and the bone provides several advantages. The first is that since we have innervation of the ligament, we can have a very fine control over jaw movements. There are many reflexes to the forces that the ligament senses during chewing, and so we can control jaw movements like we do with fingers when we adjust the grip over an object. The second advantage is that we have a damping effect. Since the tooth can move into the socket, and it moves when we apply an axial load, like what we do when we chew on something hard, and masticatory forces can be very huge forces. The tooth moves with a combination of translation and rotation, and this reduces overall the stress that the PDL is experiencing. And last but not least, we have a lot of fluids inside the PDL, not only because of the presence of the blood vessels, but also because we have a fluid component that is binded to the protoglycans and the extracellular matrix. But moreover, since we have a rich collateral circulation and the wall of the alveolar socket is very rich with foramina, those liquids can go in and out from the PDL. And so we can have an hydraulic damping effect that is very effective because it accounts for over 30% of tooth mobility overall. And this is also one of the reasons why the periodontal ligament shows a nonlinear and viscoelastic behavior. We know from in vivo studies, not on human, of course, that when we apply an axial load over the tooth...
Excuse me, do you know if in apes, in primates, there is this ligament?
Yes. All the mammals.
All the mammals? Mm-hmm. Like wasps?
Yes. Also other kind of animals, but there during life the ligament becomes mineralized, so it's already beginning. And so we observe a first phase of rapid movement that corresponds at the fluid being squeezed out from the periodontal ligament, followed by a second slower phase when the fibers became to be stretched. And when we unload the tooth, we observe the similar but inverse behavior. This is what is happening during physiological loads that we experience during chewing. But, as I said at the beginning, orthodontic loads are quite different in nature. But now, if we rethink the pressure tension theory, having in mind that we have this kind of soft interface there, things start to get more sense, because the very first phase of tooth movement is the tooth being tilted inside the alveolar socket. So there is no bone remodeling at the beginning, just movement inside the socket. And so we will have some of the fibers that will be slack. So here we have no longer bone loading, because normally inside the PDL we have a positive pressure of around 10 millimeters of mercurium. And so we can have bone resorption here because the bone is unloaded, while on the opposite side the fibers are stretched, so the bone is loaded through tension, and we can have bone apposition here. But we have to consider another important concept, that is tensegrity. So every cell in the body physiologically has experienced some tensile stress within its inner structure and also with the surrounding matrix. And every perturbation of the tensile equilibrium can produce different kinds of cellular responses. At the tissue level, we know that even light forces that are not able to produce visible effects on the PDL can produce, on the other hand, even a small amount of bone deformation. This bone deformation is observed also at a distance from the point of force application. And this deformation results in different kinds of microdamage. And we observe different kinds of microdamage on the compression and the tension side. So it could be that the small amount of deformation and microdamage to the bone can initiate the process of bone remodeling. But more interestingly, the strains that we measure at the microscopic level are way higher than what we measure at the macroscopic level. So in reality, cells are experiencing higher stress than what we measure based on the force that we're applying on the crown, for example. One of the reasons is that the morphology of the interface is very complex, and the surface of the alveolar wall is not even, but we have depressions and peaks. So in smaller region we can have even very high stress. And also the distinction between pressure and tension is more academically, we can say, because in reality we have areas of pressure and tension even on adjacent zones. So the distinction is not so clear-cut. But what happens at the cell level is even more interesting, because inside the PDL we have mesenchymal stem cells that are very sensitive to mechanical stimuli. For example, those cells, when perceive some mechanical force, can activate some particular kind of calcium channels that activate some signaling pathways that result in a modulation of bone remodeling. So the PDL itself is a kind of mechanically driven bone remodeling controlling effect, but the bone itself is very good at reacting to forces. We know that. Osteocytes are the most important cells from this point of view, and we know that osteocytes are linked in a very complex and structured network made of very small canals that contains not only cellular processes but also fluids. And so osteocytes can be triggered by mechanical stimuli not only through perturbation of the tensegrity status of the cells, but also through the shear stress produced by the fluid movements inside this canalicular system. So we have a complex interaction between the solid and the fluid component of those structures. So, as I promised at the beginning, it is quite a complex problem. There is still a lot of research and study to do because we know very little about it. But the reason for this lecture that is more a call for collaboration, we can call it like that, is that predictive models for orthodontic tooth movement will be of great help for us, because we need precise force system, because we want the teeth to move in a precise direction. We don't want back and forth movement that are bad for the tissues. And we also want the right magnitude of force, because that will keep the side effect risk to a minimum. In many cases, we are already able to do that. For example, let's say that we want to upright this molar here. We can build a cantilever with 3 points of contact here and apply 100 grams of force in this direction. We know that we will have a moment that will rotate the tooth and also a vertical component. We can get rid of that vertical component, placing another cantilever that applies an opposite force that counteracts the vertical unwanted component. This one will be dissipated by the other one and also by occlusion. And so we will observe the movement that we have planned. But this is a statically determined system. When the complexity increases, because we have more teeth connected, we are no longer able to make this kind of calculation and prediction. We know and what kind of movement we can expect to see, and it's not that we go totally blind, but we are not able to measure the force system. And things became even more complicated with modern appliances like clear aligners. You know that Italian moms get really upset when you treat bad their children, so they don't like to see all that metal, and they like a lot this kind of appliances. We don't, because here the complexity between the interface of the device disabling the force and the morphology of the teeth is very complex. So here it's a nightmare to understand the force system that we are using. But we have in the literature a lot of studies using finite element methods to address some specific clinical problems, especially with clear aligners. It's kind of a fashionable topic in my field. But if we look closely to this literature, we see that there is a lot of variation and variability. We have a large discrepancy in the methods used, the material properties assigned to the tissues, and this results in a difference among different studies of even 6 orders of magnitude. So you can imagine that it's very difficult to obtain clinically meaningful information from this kind of literature. So a proper model able to describe orthodontic tooth movement will be of great help for us. But there are, of course, many challenges to face, as I tried to explain before. I talked to you a little bit about biological mechanism. There will be many more things to say in reality. I will not talk about geometry, but I will spend my last minutes of the presentation talking about material properties. Because even about material properties, it is not so simple, and we don't have universally accepted values, because it is not easy to measure in vivo the mechanical properties of those tissues, and every time that we excise a tissue from a patient and measure it in vitro, we are changing something. So these explain partially the variation that we observe in reported measurements. But we know that enamel and dentin, that are the principal tissues composing the teeth, are quite stiff and brittle materials with anisotropic properties. we know probably more things about bone, and bone properties change a lot really inside the mouth, because the bone of the mandible is not the same as the maxilla, and also between the buccal and lingual part, or the anterior and posterior area of the mouth, properties are changing. But we have some studies about that, and we have also some equations used to assign the mechanical properties of specific areas of the bone according to the density of the bone as measured through radiographic images. Regarding the periodontal ligament, the matter is more complex, because we have a very broad variation here in method use, in also different species, different teeth. The behavior changes with the amount of force that we are applying. So we have a lot of data in the literature.
Do you have any measurement about the stiffness, young models of the tooth and young models of the bone around the tooth?
Not the tooth as a whole. There are measurements of the enamel and the dentin, but we know that when they are connected, the behavior is different.
So even the tooth is not homogeneous?
No.
The dentin is stiffer. The exterior part is stiffer.
The enamel is stiffer and more brittle than the dentin that is inside.
We should explore, the debate is the tooth deformed when it squeezes completely the ligament or not, touching the bone around? Okay, we discussed about that. So you should tell us this. Otherwise, if you make a rigid model for the bone is a story, and if the tooth is a story. If the tooth is deforming, it's more complicated.
I think that we will need experiments to say that. So we know for sure that it's a viscoelastic material, and we also have some measurements made in vivo. Those authors managed to measure the mechanical properties of the PDL in vivo on only 2 patients, but this could be some reliable, we can say, measurement to start from. In conclusion, developing a reliable predictive model for orthodontic tooth movement, or at least giving some guidelines to what should be the proper method to model orthodontic tooth movement, would be of great help, because we can do a lot of things with this kind of models, because it could help understanding the process underlying orthodontic tooth movement. It could help us in estimating the force level, and so reducing the side effects of our treatment, and also to reduce the biological costs in developing new appliances, new protocols, or even to study treatment of patients with rare pathological conditions that are difficult to evaluate in a clinical trial. Thank you for your attention, and I hope that this could be the start of some nice collaborations. Thank you.